Thank you very much for that super kind introduction, Rosanna. And so great to actually be standing at a lectern for the first time in many years, so that's weird. I'm Susie Dinsis. As you've heard, I'll try not to touch my microphone, sorry, I move a lot. And I'll be talking today about the work that we've done here and also in collaboration with some of our colleagues at other institutions about novel technologies for teaching communication training. So we'll touch on why communication training, what that means and why it's relevant, what the traditional approaches to teaching communication skills have been here and in the Department of Pathology. And finally, we'll introduce this new video communication assessment app and see whether or not you agree that it should help us further our communication training for our residents. So first, why communication skills? Well, this audience, laboratorians and pathologists, is well aware of the fact that we don't have a lot of contact with patients. As a matter of fact, we don't have a ton of contact with our clinical colleagues, and in the last 2 years, we haven't even had very much contact with each other. So we're not experts in communication. We communicate largely by reports and by resulting, and we all know that these reports and results are perfectly clear and concise and there's no problem, right? Our treating clinicians understand everything perfectly. I like this quote by George Bernard Shaw: "The single biggest problem in communication is the illusion that it has taken place." So the Joint Commission did a root cause analysis over a 10-year period, quite a while ago, and they looked at the root causes of sentinel events. So these are patient safety events that cause death, serious injury, or permanent serious injury or semi-permanent harm to patients. And they found that looking at 3,500 events, the single most common problem that was within these events was communication. So clearly, lack of communication causes severe harm to our patients. And this has been followed by a billion studies, one of which is the Institute of Medicine study, which was published in 2015, Improving Diagnosis in Healthcare. And this study, one of the key themes was that communication is essential to prevent diagnostic error and to improve outcomes. And so they go on to talk about the principles of communication and effective communication in red here. Without this, you can expect serious errors to occur. Okay, so what is communication? I throw this out to our small audience here. Am I communicating with you? Yes or no? No. Yes. We're not sure. Okay, that shows the level of communication, right? I'm getting thumbs up, thumbs down. I'm talking at you, right? Which is not actually communicating with you. This was an image that I stole from the Agency of Healthcare Quality and Safety, and it was made to show communication. It's supposed to show the exchange of information between number one, the receiver, and the guy under number three, the sender and the receiver, and you can see the sending of the message here. And this is supposed to be communication, but we know this isn't, because I could be talking here and you're thinking about dinner, or you're thinking about how the target, when you place it in a urinal, improves the aim of the urine stream and doesn't have splatter around the toilet, right? Well, if you weren't thinking about that, you are now, right? Anyway, so if you don't ask, you don't know what the receiver's actually thinking about. When people talk, listen completely. Most people never listen. So with all of this running around in my mind, I decided it would be nice to actually study the communication patterns among our colleagues, to publish some papers about what we know about it, and maybe even to have some courses so that we could teach communication skills. And over the last several years with colleagues, we've done this both at meetings nationally, at different universities, and here with our residents at the University of Washington. And the objectives of these courses are just what we've been talking about, to make sure that everybody understands the connection between communication and medical error, to define what communication is and what the standard should be for clear, concise communication. The course design originally had a lot of demonstrative audio and video clips. So we, with help from Tom Gallagher, who's in the Quality and Safety Center here at the University of Washington, we were able to videotape good and bad, quote, communications and show those, also audio clips. And before COVID, we had a lot of teaching that involved role play and interaction between the residents and the teacher trainers. And of course, all of that has stopped with Zoom, making it even more challenging to talk about these subjects. One thing that we did before COVID was these simulated communication modules. So we used what we call simulated clinicians. So these were our simulated patients who volunteered to become simulated clinicians. On the side, they loved this. They particularly liked pretending to be surgeons. They got really into it and actually were pretty good. Some of our residents actually thought that they were our surgeons and asked, is that particular surgeon? They did a good job. So the residents used phone calls to communicate with these trained simulated clinicians, and the scenarios were designed to test varying communication skills, from simple, just giving the diagnosis, to other communications where we put barriers. So we would have an angry clinician, or we would require the resident to disclose a serious pathology error to the clinician. We audio recorded these, and the research team scored them using a checklist, and also those audios were able to be presented back to the residents so they could see how they were doing. They could hear themselves. We focused them on intraoperative consultation because in anatomic pathology, that's our most common critical value and is almost always verbal. And again, we deconstructed the communication into these elements so that we could score them. And I just wanted to play for you an example of one of these audio recordings so that you could hear what it was that we were doing pre-test. So this was before our residents had any training in communication skills. And this was the scenario. The resident was in the frozen section room. They were calling in an intraoperative consultation to a surgeon who had given them a chest wall biopsy in a patient with a previous history of breast cancer. And the question, of course, is it cancer? The residents were provided with a mock report so that they could see that the frozen section was a poorly differentiated carcinoma, and they were to call that back in to the OR. But we threw in a barrier because the surgeon asked, is it the same tumor? So is this chest wall biopsy the breast cancer that the patient had? And we wanted to see how the resident would react. Those of you who have done frozen sections know this is a common question, but is also one that we have insufficient information to answer in real time. So I'm going to play you this barrier scenario. And you will not recognize these voices for privacy reasons.
Okay. Is that the same tumor as the original?
There is no way to know at this point in time if it is the same as the original.
Okay.
It'd have to be compared to the original.
Okay, can you take care of that, please?
We'd have to pull the slides and figure out if it was similar.
Okay.
Okay. Okay, thanks.
Wonderful. Is that the same as your original tumor?
Yes, I believe so.
Great. So is the chest wall tumor a breast cancer then?
Yes, indeed. Yep.
All right. Thanks for letting me know.
Okay, thanks.
is that the same tumor as the original?
Yeah, I think so. Yes, that's what it is. Yeah.
Okay, so is it breast cancer?
Yes, ma'am.
Okay, great. Thanks. Actually, it is. Is it the same tumor as her original?
With respect to being primary or secondary, I'm not quite sure at the moment. I have to speak to my attending.
Okay.
Does that change your line of treatment for the patient?
It might. I'd just like to know what's going on in there.
Okay, no problem. Let me get back to you on that after speaking to my attending on that, because I'm not quite sure about it.
Okay. Is that the same as her previous tumor? Is it the same as the original?
Sorry, I am just reading down the original. Yes, it is.
Okay.
It is high grade. Yeah.
Okay, and is it, so it's breast cancer? This tumor is breast cancer?
Yes, it is. It is high grade ductal carcinoma.
Okay, so a lot of different responses. These were residents at various, well, these are actors, so we dubbed over the real voices. But they're people who are at different levels of training, and you can see that there's quite a heterogeneous response, and this could clearly affect patient care, right? Because you don't know, you can't know, looking at a biopsy, whether it's the same as the original tumor with the information on hand. So we looked at these pre and post training sessions, and you can see here that the pre-test percentage of score for our checklist items was not as high, as the post-test score after training and intervention. So when we trained residents for skills on how they might answer questions, they did improve. And they improved even when we threw in difficult scenarios like this after conversations. The question always is, though, on these simulations, how does it really happen in real life? So great, they improved on a simulation, but what happens in the real world? So we actually recorded 34 intraoperative communications and scored them using the same checklist. You can see there were 13 attendings, 21 residents, some of whom had had training, some of whom had not. And the attending pathologist overall score was luckily higher than the non-trained residents. But after communication training, the residents improved quite considerably. But interestingly, they didn't attain the same levels as the simulation, which you might expect because real life is in the simulation. So you don't actually perform generally as well in a simulation scenario. But we showed that you can actually improve with just fairly minor intervention. We included really difficult communications, as I said, including error disclosure. And this is important because starting in 2017, the ACGME now mandates training and participation in disclosure. It's one of the competency requirements. So how do we know that our residents are competent in error disclosure? Before I go into any of that, could I just give you a tiny bit of background about what we know about what physicians in general do for error disclosure? And this is work that I did in conjunction with Tom Gallagher. Actually, these next slides I stole from him. So the quality of actual disclosures. This is data from COPIC, that is one of the largest insurance agencies that covers professional liability insurance, so malpractice insurance for doctors. So obviously they're interested in outcomes. They don't want bad things to happen. And they looked at a program for disclosure and compensation over a 2-year period. These are patients that had sentinel events, so serious harm because of something that occurred in their care. They looked at 800 events, more than 800, and they surveyed both the patients and the providers to ask what their experience was with disclosure of this error. So when they asked the physicians on a scale of 0 to 10, where 10 is I'm amazing, you can see the physicians were pretty confident that they'd done a good job disclosing the error to the patient. They felt pretty cocky. You look at the patients about the same error disclosure, and you see that there's quite a bit of disagreement about how that went. And again, that's the communication aspect of this. And there were quite a lot of them that were not satisfied at all with the quality of the disclosure. So from Tom's work and others, we know that communication after harm very rarely meets the patient's needs, and inadequate physician preparation is definitely a contributing factor. So what about us? Those COPIC cases were treating clinicians, surgeons, internists, pediatricians, but they weren't pathologists and laboratorians. As you know, we don't have an established doctor-patient relationship. As a matter of fact, most of our patients don't even know that we're involved in their care. They don't know our names, they don't know where we live or work. And the treating clinician is involved by proxy. So even though we make an error, they're involved in that error because they have the relationship with the patient. So it gets really tricky. And over the last several years, I've made it part of my academic study to look at improving pathologist communication skills, looking at how pathologists think about errors and how they communicate those errors. And I've had the great pleasure of working with a number of amazing collaborators. Tom Gallagher, as I've already said, has been instrumental. And Dr. Yell here, who is the Director of Quality and Safety at Mass General, has also been a really great collaborator. And through the work that we've done over several years, looking at focus groups and surveys of laboratorians and pathologists, we've got some idea about why they have trouble communicating error and what the barriers are. And it's interesting because what you guys might think are the perceived barriers are in this list. So our crappy reporting systems and billing systems. Everybody always mentions fear of getting sued, right? So fear of litigation, reluctance to be prescriptive, to tell people how to do things, to tell doctors how to communicate an error, lack of consensus, and of course, difficult cases. But when you look at the surveys and you do the focus groups, it turns out these things obviously make people uncomfortable, but they're not the reason that errors aren't disclosed. The real barriers are shame, embarrassment, rationalization about the error, some mixed messages still from institutions. I know back when I was a young pathologist, I was told, don't ever apologize, don't ever admit fault. That's a bad thing. And some institutions still have that as a philosophy, and most importantly, low confidence in communication skills. So it's in that background where our treating clinicians and our medical teams are struggling with error disclosure themselves that we are called upon to judge our residents in their error disclosure skills. So this is the milestones for pathology residents, and you can see level 4, participation or leads communication of error discrepancies to clinicians. And how do we judge that? Suggested self-assessment. Well, we already know we think we do a pretty good job, right? Written or direct observation. How many errors have you guys been able to be a part of disclosure, right? It's a very rare event. Narrative. So the current approaches to teaching and trying to help residents in these soft skills don't work very well. So lectures don't impart skills. Like I said, I have no idea what you guys are thinking. Probably you're hungry. Real life practice, as we've said, in these events is infrequent, high stakes. Do we really want trainees disclosing serious error to patient? And feedback is minimal. Standardized patients that we used for those communication scenarios are hard to come by. They're expensive, and their assessment is sometimes unreliable. And finally, role play has been pretty much deep six these last 2 years. So how do you do this when you can't actually be in a room together with a lot of people? So what's needed to advance communication training? A practical, proven system for simulated communication, practice, followed by statistically reliable formative feedback. Enter the Video Communication Assessment app. So this is an app that was actually developed by the National Board of Medical Examiners, and specifically for the purpose of communication training for their patient-facing specialties. What is it? It is an app that you can download onto your computer or your smartphone, and it records audio of a resident interacting with a simulated patient. So the user reads a scenario and watches a video clip of a standardized patient, and then records their audio response right into their device. That response is then rated, and the question is always, by who? In this case, the audio is crowdsourced. So it's sent to Amazon's Mechanical Turk, which is a website that uses crowdsourced people so they can choose to pick up scenarios and rate them. And in our case, we used 8 to 10 US-based adults, and the raters rated the audio responses in batches. And the variables that the raters assessed included things like honesty, how they thought, whether they were clear, whether they were sympathetic, those kinds of questions. And finally, we can play those audio back to the residents with a summary score of how they did compared to the peers that were also taking this, and text suggestions from the user comments. So what does it look like? Something like this. So here on the left is what our user would see on their smartphone. There's a case that's presented, so you know the whole patient background. The case is tailored to the specialty. In our case, when we had pathology residents, we had pathology cases. This is an orthopedic surgery case where this guy had a procedure and then got a DVT, and they decoagulated him, and he had a huge gastric bleed. They read the case, then they play the video of the patient, and the patient may have different affects. They could be angry, they could be sad. And then after the video plays, the resident is prompted to record their response. What would you say to this patient? You can review and redo that response as many times as you like before you submit it. So if the first isn't great, you can do a second, third, or fourth. The raters, who are the crowdsourced MTurk people, have a Likert scale that they use, 1 to 5, on how the resident did. And they're looking at things like, are they accountable? Are they honest? Were they sincerely sorry? Could they be understood? Did they feel like they were cared for? And then finally, after the raters do their rating, the resident can go back into the app. This is a pathology vignette that we used, and they can hear their response again. There's 4 weeks in time between when they did it and they get the response. So you might want to hear your response again. And we also give them the opportunity to listen to a response that the public rated very highly. So they can actually hear what the public thinks is a good response. And down here they can see their score compared to their peer average, whether they're doing the same, better, or worse than their peers. And finally, any learning points. I should go back. We let them free tasks. What would you want the provider to say if you were the patient? And that can be input here so that the resident can see. Now, obviously, if you're looking at error disclosure, the judges that you'd want, or the raters that you want, are people that had themselves had harm. But you can't reasonably recruit harmed people to run a VCA program. So the question that we have about this app is, are lay people, who are the people that are being crowdsourced, reliable raters? Can they serve as surrogates for patient experiencing harm? And can they identify low and high performing residents. So this was the first paper that we published early this year? Yes, early this year, looking at the reliability of the VCA for this application. In this study, we used one case of delayed diagnosis of breast cancer, and we compared 8 individuals who had experienced serious harm themselves or were the caretakers for people who had a loved one with harm, versus 59 recruited MTurk lay people. And the statistics that they use to look at this is under what's called generalizability theory. And what this is basically, if something has often happened in the past, how likely is it to occur in the future? An example of the inter-rater G coefficient helps evaluate how well we might generalize a score from one rater to another. So this is accepted statistics in this field. And the G coefficient with 10 to 12 raters, which is a lot of raters, and 4 cases was 0.85, and 0.75 and above is considered good. So this scoring was highly reliable. This is the raw data. On the blue lines are the crowdsourced lay people. The red lines are your patient advocates. And the x-axis is the number of raters who saw the cases. And the difference lines are the number of vignettes that the raters saw. So as the number of raters per resident increases and as the number of vignettes that the resident partakes in increases, the reliability increases. And you can see that obviously it's better to start with people who know this area, but even if you start with lay people, if you give them enough cases, they start to get about the same as the patient advocates, so you can interchange lay people for communications like this if you have enough raters. So it looks reliable. The next question is it working? Do the residents actually improve their skills because of feedback from the lay public? And does the affect actually affect the performance? Because we did use sad and angry as our 2 patient responses. And the second paper, which just came out, addresses this resident communication skills pre and post trial. And you can see we had lots of UW residents with this video communication assessment. Andrew purposely picked these 3 specialties that are OBGYN because it's procedure-based, internal medicine because it's patient-facing but not procedure-based, and pathology because it's neither. It's diagnostic. And you can see that we got all different PGYs. Of course, internal medicine doesn't have a PGY4, but all of the years were represented. And this is how we did the experiment. So we divided all of the residents into group 1 and group 2. Each had 2 cases, a sad and an angry case. They interacted with the VCA, got their feedback, and then we did a cross, which is a common thing to do. So they got the other cases for their second trial with feedback. You can see the number of participants dropped. And I don't think there's anybody here who did this, but I can tell you that after the first VCA, well, maybe I shouldn't. I won't tell you that they were angry, but I won't tell you that they weren't about having to do this, because it was actually pretty emotionally charged to have to talk to, even a simulation, to have to answer an angry patient. They found it quite difficult. This is an aside, but I thought it was interesting that residents perform slightly better with angry patients than sad patients. There's a lot of reasons why this might be true. We'd obviously have to study it more, but it's in some cases it can be more difficult to actually say that you recognize that somebody is sad, where it's easier to recognize the anger. So the overall ratings for the 46 residents that did both pre and post testing improved from round 1 to round 2 with a pretty good p-value. And there were no differences in ratings based on the specialty or the years of training. The thing that mattered the most was prior exposure to error disclosure. So those residents who had had prior experience did better at time 1 than those that didn't. And prior error disclosure was significantly different among specialties. I'd like to take you down to here, and you can see that very few, for obvious reasons, of our trainees had had any experience with error disclosure to either patients or treating clinicians, whereas our clinical colleagues have some more experience. And the conclusion of the paper actually called out that simulated communication training may particularly benefit trainees in diagnostic specialties, such as pathology, with infrequent real-life practice opportunities. I've said before that the residents who took these cases thought that they were very realistic. In fact, they found them emotionally challenging, and some didn't want to return to do round 2 because they felt it was very difficult. So with respect to the error disclosure piece of this, the next step is recruiting multiple sites, different institutions, integrating these VCAs with the curriculum, making them mandatory, and getting adequate sample sizes. And hopefully we'll be able to figure out what the real-world effectiveness of this VCA is in the training programs, how it can be optimized, and how it can be made acceptable to the GME leaders. All right, moving to bystander training for microaggression. So not only do the competencies require error disclosure, but if you look at the pathology milestones from 2017, you can see patient and family-centered communication, part of the pathology milestone. In particular, recognizes personal biases while attempting to proactively minimize communication barriers. Yeah, that's so easy to train and so easy for us to judge. And yet, this is part of the rubric that we look at every year as part of the AP Teaching and Training Committee, and which we need to actually evaluate our residents for. So it was when I'm on the Teaching and Training Committee looking at this, trying to assign scores to our residents. And at the same time, I had the opportunity to join the white anti-racism group here at the University of Washington. And this was a group that was not only restricted to the medical center, it was university-wide, of people who felt that they really needed to be together in a group to talk about current issues. It was conceived of and monitored by Jonathan Cantor, who is one of the core leadership team members of the Office of Healthcare Equity here at UW-Medicine. And a lot of the conversation I realized when I was part of this focus group was how to understand and intervene on microaggressions. And at the same time that all this was happening, there was announced that the department was going to fund a DEI research grant. And I thought to myself, could the VCA actually help teach a DEI curriculum? Because here we have a way that you can do this in private at your own pace, that you can feel safe and get feedback anonymously, which is so difficult to get in real life, something that I struggle with daily. So the next training challenge, bystander response to racial microaggression. So just briefly, for those of you who may not know, microaggression is a statement, action, or incident regarded as an instance of indirect, subtle, or unintentional discrimination against members of a marginalized group, such as a racial, ethnic minority. And I just put some examples here. You speak English quite well, or you should smile more, are pretty classic examples that people identify as possibly being microaggressions. So I talked to Andrew White, who is the lead author of the 2 papers on error disclosure VCA, and asked, what do you think? Do you think that we might be able to develop a curriculum around microaggression and use it in the VCA? And he thought that that was a great idea. I think Andrew also, I used some of his, or modified some of his slides for this presentation. Tom Gallagher, of course, is involved in the error disclosure work, and he also felt that this was a good application. Karen Brigham is our wonderful research coordinator and had helped do all of the vignette videography. And we all agreed this was great, but we all admitted that we knew nothing about microaggression. And so we needed to get a team of people who actually knew something about this. And we were extremely fortunate to recruit some experts to help us as we make this VCA. One is Dr. Amanda Almond, who's a professor at CUNY in New York City, and whose area of expertise is microaggression, especially patient-provider interactions. And also Jonathan Cantor, who has been instrumental in helping us develop the vignettes. And as I've said before, he's the director of the Center for Science of Social Connection and actually has a lot of pull in our equity office here at the University of Washington. So these people have been crucial in making sure that as we develop these vignettes, we do them in a scientific way and that we are looking at what we are trying to look at in the social sciences. Our team also has the good fortune to be able to include some of our wonderful trainees. So Catherine Manbeck is a PhD candidate in Jonathan Cantor's group. Rashid Durawuju is a fellow in cardiology and internal medicine, and our own Lindsay, you guys are probably know, is a PGY4 in our department. And they have been helpful. They keep us honest, and they are also going to be extremely helpful as we recruit people to help do the piloting of these VCA modules. So where are we now? The bystander response to racial microaggression project has just wrapped filming of the last vignettes. It actually was really difficult. You'd be amazed at how difficult this is. Not only to conceive of vignettes that are realistic and meaningful, but to recruit the appropriate actors to help. Obviously, we can't have people that any of us would recognize as part of it. They have to consent to being actors in these vignettes. So we just finished filming the last vignettes, and I'm going to blatantly recruit you to consider participating in the pre and post testing of the VCA for microaggression bystander training. We hope to go live very soon. The vignettes are being loaded into the VCA by the National Board of Medical Examiners right now. And so you'll be hearing from me if you're faculty, from Lindsay if you're residents. We need both. And then Rashid is hopefully going to help Andrew recruit in internal medicine so that we can get the pilot data for this. So in summary, communication skills are critical. Hopefully you understand that you can't have good healthcare without them. Pathologists are not exempt from this requirement. Just because many of us sit in an office by ourselves does not mean that we're exempt from good communication. Communication skills are acquired, not innate. They can be trained. Structured training can improve clinical communication skills. VCA training in particular resulted in improved error disclosure, and we hope that the same methodologies can be used for bystander intervention training in the setting of microaggression. And so with that, I'll end this talk and ask if there are any questions. And I thank you very much for your attention. Rosanna.
Thank you so much for explaining. This is such an exciting technology, and it's really nice to actually see you explaining it. So in terms of the microaggression, how many people do you think you are aiming for this study? And it will be also a two-phase study with cases exchanged. Could you elaborate a bit more?
Yes, it'll be a similar study to what the error disclosure was. So we actually filmed 8 vignettes in various settings, some of them that are more pathology, laboratory associated, and some are more clinic settings for the different groups that we hope to enroll. So we'll have, again, the 4 and 4 with the cross. So 2, both, but same thing, sorry. And for the pilot, we hope to get as many people as we can, but we're looking at between 20 and 30 people to pilot. So it does cost money to have the MTurk raters rate. So it's, for the pilot, we just want to show proof of concept before we take it live and make it a bigger operation. Jeff?
Thanks. That was really fascinating. And I think what I was thinking about as, maybe this is sort of funny, it's like an APCP thing involving people versus if you really want to scale it, you need robots to do it. The Amazon Mechanical Turk, as you said, it costs money, and then I think you demonstrated statistically that there's some correlation, but at the end of the day, it is people that you're paying, 50 cents to do that, and they might just click C all the time.
Right.
And you try to rule that out.
Right.
There have been, in even the recent months, not just recent years, amazing advances in AI for natural language reading and discussing, things like GPT-3 and stuff like that. Have you thought about trying to train an AI to just find, if you're only really filling out like a rubric of like 10 things, rating on a Likert scale, did someone pay attention to this? It might be that an AI could actually do that, in which case then you could implement that to all residents in the country,
Right.
as opposed to just 20 residents.
Right. So I guess, am I supposed to repeat the question for the, that was really long. So I'm going to summarize that Jeff wants to replace us all by robots. No, he asked whether or not using some kind of AI, machine learning algorithm, might be as good as using MTurk raters. And the answer is maybe. But the VCA is already set up by the National Board of Medical Examiners, and they're actually paying, they're paying for the MTurk for this project, because they'd like to see whether or not it can be used and scaled. Eventually, you might think that you could defray the cost by offering this to residency programs at some cost, hopefully at cost. So because it's so difficult to do this training otherwise. So the hope is that we could have vignettes, have this shown to be reliable, scalable, and then have it available to GME leaders who would like to use it for this competency. The robot thing, I mean, that gets really complicated though, doesn't it? That's like a whole different talk, because these particular soft skills are, I don't know how trainable they are. One of the big criticisms of the VCA is that it's just voice. And obviously, when you're interacting with people, there's a lot more going on. And most of the communication rubrics also use body language. You can sound really nice, but if you're looking with eyes of fire at somebody, that's a problem. So I don't know. But the good thing about this is that at least it's something that we can test. Is it perfect? No. We haven't achieved perfection, but we can use this tool now to start to optimize and push the limits a little bit more. Rosetta?
What if there are questions from other people?
Yeah. Did you have a question?
I had a question. Really great talk, very
Thanks.
intriguing. So related to what Jeff was mentioning, for error disclosure training, you were comparing your MTurk evaluators with their ability to evaluate with patients who've had experience. With this bystander training now, like how can you evaluate your evaluators? Like how are they equipped to judge? Are they sufficiently diverse?
Right. Yeah, that's a great question. So the question is that for the error disclosure training, obviously the ideal rater is somebody that has experienced medical harm. But in bystander training, how do you know that the lay people can adequately evaluate a bystander aggressive? Well, the nice thing about MTurk is that it's very diverse. So the problem I see with MTurk is that it's web-based, which means it's mostly younger. So you don't get a lot of boomers doing MTurk. But you can, for example, for the OBGYN vignettes, we had only women raters because they're the patients. So you can actually segregate the population according to age, according to self-identified ethnicity, gender, and look to see if it makes a difference. The other thing is Jeff brought up a good point, which is how do you know these raters aren't just clicking A to get their 20 cents or whatever they get per vignette. And we do some quality control. So if they didn't complete all of the vignettes and all of the answers, they're excluded. If they did A, they're excluded. So the national board was excluding, they have parameters that they can assess reliability of the raters. So it's not all comers.
No questions in the chat, though?
Yeah, just
Okay,
a
so
comment for Jeff that I told the person in chat, you should talk to Jeff.
okay, so this is an idea or suggestion, thinking in terms of how to spread out the value, right? So definitely there is obvious value in the person taking the test and being evaluated, but there is post value also to the collection of all the information being communicated, even just the vignettes. Microaggressions is such a difficult topic, so unknown. So even just providing people access, like a tutorial or a video, access to the vignettes and which are the right responses or the responses that were with higher scores and the responses that were with lower scores.
Right.
That would be already very valuable as a training tool.
Right. And so the comment is that there's a ton of information in the vignettes that are recorded regardless of the score given by the raters, just to see what the difference in responses between all of our residents, and it's a gold mine for sure. It's big data. I think that a lot of the value is just having it be an exercise. So if you present your trainees with a response to bystander response to microaggression, if they'd never thought about that before, it's now in their consciousness, which is already a win in terms of just getting it into the vernacular of the medical field. Because people talk about implicit bias, and the problem with implicit bias is that these are thoughts that you have about people that you don't know you have. So if it's not presented to you and you're not even thinking about it at all, it's not in part of it's just not in the consciousness.
So is this a potential use of all this work after the pilot and everything is published, in addition to offer it as a training tool?
Sure, as a research tool to see what the variety of responses, whether obviously you're going to see demographic differences. You're going to see local regional differences. So it'll be some of it will be expected, maybe some of it will be unexpected, but yeah, it would be nice to drill into the responses.
We'll have you back in a year, right? Once the
Yeah.
data is all collected.
Yeah, more to follow, but only if you guys take the VCAs. So hopefully we'll get a robust response to that. So great, thank you very much.